Hello, everyone, and welcome to the section of Civil Rights and Social Justice's inaugural 2018 Rapid Response webinar. For the 2017-18 bar year, our goal is to rapidly respond to government actions and they impact civil rights, civil liberties by offering free webinars, commentary, podcasts, social media posts, and other information from our subject matter experts. We encourage you to check the section website, www.americanbar.org/CRSJ, our Facebook page, and our Twitter handle at ABA_CRSJ for more news and information and replays of our great programming. And if you like our work, we invite you to become a member of the section and collaborate with us on projects you want to develop and offer to our members and the general public. Today's program, entitled Recently Approved Waivers and Their Implications, discusses a letter issued earlier this month by the Federal Medicaid Agency allowing state Medicaid eligibility on work requirements. Their agency also approved a waiver application from Kentucky that includes a work requirement along with other features that will reduce coverage. Our panelists will discuss the waiver authority, focusing on the history and current status of pending waiver requests and the legal issues raised by them. If you have questions during the program, you can click on the questions drop-down box and write to us, and we'll do our best to get your questions during the last 10 to 15 minutes of the program. Our panelists today are Cindy Mann, a partner at Manatt, Phelps Phillips in their health practice, and formerly with the Centers for Medicaid and Medicare Services, where she led the administration of Medicaid, CHIP, and the Basic Health Program for more than 5 years during the implementation of the Affordable Care Act. With over 30 years of experience in federal and state health policy, she now works with clients to develop and implement strategies from around federal and state health reform, Medicaid, CHIP, and delivery and payment system transformation. She is joined by Jane Perkins, the legal director at the National Health Law Program, where she leads the organization's effort to ensure that healthcare protections are lawfully implemented nationally and at the state level, and manages the litigation docket. She has served as counsel in more than 30 high-profile lawsuits across the country to protect and advance the health rights of low-income and underserved individuals. Jane is also a senior attorney at the Network for Public Health Law and a vice chair of the section's Health, Rights, and Bioethics Committee. We're delighted to have them join us today. I'll now turn it over to Cindy to begin our program.
Thank you very much, Paula, and it's great to be here today, and welcome to all of you. I'm going to start off by giving a little bit of background about the Medicaid program and then quickly moving into where we stand in terms of the development of new policies, really very significantly different policies than have ever been adopted in the Medicaid program before through what are called Section 1115 waivers. So if you want to move to the next slide, please. Medicaid, could you move to the next slide, please? Thanks. So Medicaid has been around since 1965, and it is now the single largest health insurance program in the country. And it also is the single largest source of payment for long-term care. So there's a lot of talk, particularly around the work requirements in terms of the so-called able-bodied people covered by the program. Most of the people in the Medicaid program are kids, and most of the spending in the Medicaid program is for people with disabilities and for the elderly. So it's a very heterogeneous and large program. If you could take it back to the earlier slide, please. I'm still on the first slide. Together, the program spent about $566 billion. Excuse me, could you bring it to the slide before this? To about $566 billion in 2016. It's a large program, large for states and large for the federal government. They both share the cost of the program, and the cost, the dimensions of that share, how much the feds pick up and how much the states absorb, is set by a matching rate that varies by state according to the relative per capita income of a state. It never goes below 50%, and for the expansion population, it never goes below 90%. And the average across the country is now about 58%, meaning the federal dollar, for every $100 spent, the federal government will spend $58. Important to understand as we think about the waiver policies is that the Medicaid program is a mix of both federal minimum standards and state options. So without a waiver, states have a fair amount of flexibility around covered populations, eligibility, and very broad flexibility with respect to delivery system and payment rates and methodologies. It's not unbridled flexibility on that area, but very broad. And so it is often said that if you've seen one Medicaid program, you've seen one Medicaid program. There's a great deal of variation across the states, and that is predominantly due to the options and the discretion embedded into the regular rules of the program. Now, if we go to the next slide, the Affordable Care Act, we can go to the next slide, please. The Affordable Care Act, I think as everybody knows, made some significant changes to the Medicaid program. And one, although it's certainly not the only significant change to the Medicaid program, excuse me, could we go to the next slide, please? Is that it became essentially the foundation of a new coverage paradigm that was created by the Affordable Care Act. The goal of the Affordable Care Act was to make sure everybody or nearly everybody had a source of affordable quality health insurance coverage. If you could go back to the slide before for a minute, please. And the paradigm that was created by the Affordable Care Act is that Medicaid would be the base of that new coverage paradigm, covering all low-income adults and children. And then if those individuals didn't have affordable coverage through the workplace, they would be able to access coverage through the marketplace and get a subsidy through tax credits and cost-sharing reductions. So, of course, as probably everybody on this call knows, in 2012, the Supreme Court determined that the Medicaid expansion was, in essence, optional with the states to do or not to do right now. All states except 18 have adopted legislation to expand the Medicaid program, but in those 18 states, there is a gap in coverage below 138% of the poverty line. So if you go to the next slide, please. The results of this big change in coverage was a historic drop in the uninsured rate across the country. And it was driven certainly by more people being able to access affordable coverage through the marketplace and through tax credits, but also very much because of the important role that Medicaid has played in terms of covering more and more people. And what you see here is that if you look between 2013 and 2016, nationally, the uninsurance rate went down from a little under 20% to 13.7%. It is a historic low in the nation's history, at least as long as we've been collecting data on uninsured. And then separately, we've identified in this slide the uninsured rate changes for states that had expanded Medicaid and for those who had not expanded Medicaid. And you see very significant and much deeper drops in uninsurance in those states that had expanded Medicaid. Now, let me turn to waivers a little for the next section. If you go to the next slide, thank you. Let me give you a little bit of backdrop on waivers, and I'm going to mostly talk about the policy, and Jane will pick up on the legal issues. So you have a Medicaid statute, Title 19 of the Social Security Act, which, as I said, sets out federal minimum state options, sort of the guardrails, the federal guardrails of the program. But in addition, the Social Security Act includes Section 1115, which grants the Secretary of HHS the authority to allow states to use Medicaid dollars in ways which otherwise would not be authorized by Title 19, by the Medicaid law. And there are certain requirements for the exercise of this authority. Probably central is that the Secretary has to determine that the proposal that she or he is reviewing from a state furthers the objectives of the Medicaid program. It must be authorized also for a demonstration purpose, subject to evaluations. These are supposed to be experimental demonstrations. As you can imagine, it's not intended to be a permanent authority for the state, for the Secretary to simply circumvent the laws of the land. And it has to be a provision that affects a segment of the Medicaid statute, and I won't get into detail, but there are certain parts of the Medicaid statute that are off limits for 1115 waivers. Not in the statute, but by longstanding practice, waivers have to be budget neutral to the federal government, meaning that the federal government, to grant a waiver, has to determine or has charged itself with the responsibility of determining that the waiver will not cost the federal government any more than what the Medicaid program would have cost in the absence of the waiver. There are comment periods and public input opportunities as part of the law governing these 1115 waivers. The common uses of the waivers have really varied over time, as you can imagine, as different priorities have been front and center for different states and different federal administrations. In the most recent period of time, before the Trump administration, the most common uses of waivers were in these 4 buckets. First, while most states were already running their programs through managed care, meaning they contract with managed care organizations to provide the services that people access, what was going on in the last 5 or 10 years is states were turning more to managed care for new populations, for the elderly and the disabled in particular, who had largely not been in managed care previously, and to new services like long-term care. States were also using 1115 waivers to get some upfront federal financing and support for delivery system transformation through those waivers. So we had about 12 states with delivery system transformation waivers, and those waivers are still in effect right now, but we haven't had any new ones be submitted since the new administration came in. We also have some states that used 1115 authority to be able to construct uncompensated care pools, dollars that hospitals usually in the system, sometimes physician groups could draw down to address the uncompensated care in their facilities. And finally, we had expansion-related coverage waivers. Now, of the states that had expanded coverage after the Affordable Care Act was passed, expanded coverage through the Medicaid program, and after the Supreme Court's decision, the vast majority did so without a waiver. They used the normal mechanism through a state plan amendment or through various state plan amendments for a state to come in and to set up its expansion. But 6 to 7, depending upon how you count it, states decided that they wanted to move forward with expansion, but in ways that would otherwise not be permitted under federal law, and they sought waivers to do that. And mostly it was around issues of premiums and copays, health savings accounts. So let's look at the new waivers, new direction under the Trump administration. If you go to the next slide, please. So until the Kentucky waiver that was approved last week, we didn't have any actual new policy from the Trump administration in terms of the direction that they were intending to go, but we certainly had very strong signals from the administration. In March 2017, the day that the current CMS administrator, Seema Verma, was confirmed and became part of the administration, she and former Secretary Price issued a letter really emphasizing their intent to be flexible with states and to use 1115 authority to address state issues. And they particularly called out that they were interested in innovative approaches to increase employment and community engagement, which is tied to the work requirements type of waivers, and also interested in waivers that would better align Medicaid to what private coverage might look like, particularly for the non-disabled adults. There was a follow-up speech in November of 2017 where Administrator Verma focused on coverage, particularly on the expansion adults. And you'll see through this quote a really strong focus on moving people, the quote is move up, move on, and move out for the so-called able-bodied individuals through community engagement and other activities. So here's, if you move ahead to the next, actually, you can go to 2 slides ahead. This next slide thank you. This next slide shows you where we are, not on all waivers that are before the department right now, but on the waivers that are in the genre that we're talking about today, what we're calling coverage waivers. Waivers that, I'm sorry, could you go back a slide, please? Thank you. Because they're largely affecting eligibility, the conditions of the rules of participation in the program. So at this point, we have 13 pending waivers and 1 approved waiver. The 1 approved waiver is from the state of Kentucky. And what you see here are the kinds of things that these states have sought waiver authority for, very consistently, similar to the kinds of waivers that we saw during the Obama administration. A lot of focus on premiums and cost sharing, but we also see 10 states, including Kentucky, that have work requirements in their waivers, and you can see some of these, the other features. If we go to the next slide, I'm going to dig in a little bit on some of the features of these requirements. So I had said that premiums are not new in the sense that the Obama administration had approved some premium waivers. What is new with the new group of waivers is that many of them, though not all of them, but many of them would charge premiums above 2% of household income, which was the guardrail that was established in the Obama administration, and is similar to the cost in the marketplace of premiums for somebody at that same income level if you're above the poverty line. We also have some waivers that would end coverage for people who didn't pay their premium, even if their incomes were below the poverty line, and that is a feature that the Obama administration did not agree to. And we also have one waiver that was approved during the last administration. Indiana had a lockout for non-payment, meaning if you don't pay, not only are you disenrolled, but you're kept out of the program for a prescribed period of time. In the case of Indiana, it's 6 months. And we have other states, including Kentucky's approved waiver, that has a lockout provision. Cost sharing, a couple of different features that different from what have been approved in the past. But let me go to the work requirements, because I know that's a particular point of interest. The last administration determined that work was certainly an important goal of government programs and of states moving forward, but that it was not an objective of the Medicaid program. So the last administration did not approve any work requirement waiver requests from states. Some states that got expansion waivers under the last administration referred people to work, to job training, to services that might assist them in finding employment, but there was no eligibility tie to doing work and training activities to being able to maintain your health insurance coverage. Other of the changes that are being considered are to different rules on eligibility in terms of lockouts for failure to renew. That's in the Kentucky waiver. Some changes on benefits, although less so than in some of the other areas, mostly around ending retroactive coverage, which is when a person's eligibility actually begins, and limiting or eliminating medical transportation to medical care in non-emergency situations. So the other change, too, to note is that we have some states, Maine, Wisconsin, and Mississippi are examples that have sought these policies and sought to apply them not to the expansion population. These are 3 states that haven't expanded Medicaid, but to apply them to what's often referred to as the more traditional Medicaid program. So let me just talk about implications and key questions, and then I can turn it over to Jane. So if you would move to the next slide, is just the title slide. So the slide after that on state rationale. States have given a variety of reasons for their waivers, and you could move the slides forward, please. That's good, thanks. Maine, for example, which has a work requirement, is seeking to increase employment and wage earnings of able-bodied adults. Indiana, no, I'm sorry, could you go back to the slide before this? Thank you. Indiana, the centerpiece for Indiana's waiver was to set up health savings accounts. In that way, they were looking to promote better understanding of the cost of care and member utilization of health care. Wisconsin has proposed drug screening and has said that its goal was to connect people with substance use disorders to treatment. The consequences, however, go beyond some of those objectives. If you go to the next slide, please. Thank you. What we see in some of these waivers are the states themselves projecting significant coverage losses. Kentucky projects Medicaid enrollment will drop by about 95,000 people over the 5 years of the waiver. Ohio had a waiver that was submitted and rejected. It'll be resubmitted again, there's plans to resubmit it again. It projected that its waiver, which focused on premiums, would have resulted in coverage losses of between 125,000 and 140,000 people in each year of the waivers. Important to remember, and this particularly comes up in the work requirement context, is the people probably most at risk of losing coverage are not the people necessarily who are the target of providing work supports to, but are the people who the state and the federal government would exempt from those requirements because they are too ill to be able to comply, because they have mental health or substance use disorder problems or chronic illnesses that they need to address, or that they're caring for a young child or a disabled individual in the household. The problem often in the history of the Medicaid program is people losing coverage because of paperwork and not really being able to move through the system. We're also going to see, I think, likely interruptions to care. So when you're on, if you meet a work requirement, you're on coverage. If you fail to meet it, you're off coverage. There's an on-ramp in the Kentucky waiver. You can get back on coverage. But that back and forth, which is often referred to as churning, really will disrupt care, which has obvious implications for the individual, but also implications for delivery system and payment reform strategies that many states and health systems are embarking on. And there's also a likely impact on cost as people go into emergency rooms and delay care as a result of the loss of coverage. And there's something which I like to call opportunity loss, which is that there's not a lot of state capacity at Medicaid programs. They run very thinly. Their staff is very thin. They do an amazing amount of work. And when a state is implementing any of these very large, significant new initiatives, it necessarily takes their attention away from some of the other work that they're doing, which over the last few years have really been focused on improving, now that there's more of a foundation of coverage, to improving care and lowering costs. So I'm going to just wrap up with some of the key questions and then turn it over to Jane. If you go to the next slide, please. Some of the policy questions you'll see here are ones that are also pretty relevant to the legal claims, but I'm posing these really as important policy questions. Do proposals like some that have been put forward and the Kentucky that have been approved further the objectives of the Medicaid program? I think the debate, for example, about work requirements in the Medicaid program ought not to be necessarily about is work and work support good? Are the agencies really prepared to help people to move to better jobs and more stable employment? I think the question really is whether that activity belongs in the Medicaid program and as a condition of people's eligibility for health care coverage. I think that's really the key policy question for some of these waivers. Medicaid is a unique program in the sense that it covers people who by definition are low income and people who are often in very poor health. So how will these features and the potential need to prove your eligibility in different ways affect people in these different situations? A really important question is, are these really going to be experimental approaches? Are states going to test a hypothesis and have an evaluation? And are we going to learn from that before we do the next 3, 4, 10 other waivers that are approved? Governors often want a waiver that was granted to another governor, granted to them, and they're not really interested in waiting for an evaluation. But as we get into areas that are really more on the edge of established policy, these kinds of wait and see does it work approaches become more and more important. How will the waivers change care and the way care is delivered? And then I will also say, since we do have litigation that has been filed in the state of Kentucky, an important question for a lot of states that I've heard discussed over the last week among them is, what do I do about moving forward if there's going to be litigation? Do I wait and see how the litigation comes out before I invest the resources in moving forward on these initiatives? So with that, let me turn it over to Jane.
Next slide. Thanks, Cindy. And thank you for having me, ABA. In terms of who NHELP is, the National Health Law Program, just very quickly, our contact information is on this slide. My email address is on the title slide. Please visit us online, and if there's something that comes up today that you'd like to follow up with me about, please don't hesitate to email me. I will just point out that over our nearly 50-year history, we have formed strong and deep relationships with state and local partners who engage in legal advocacy. We work with poverty and legal aid advocates in all 50 states in the District of Columbia. We have disability rights advocates whom we work with in all 50 states in the District of Columbia. Through some generous foundation funding, we are able to establish health law partnerships in around 16 states that are seeing restrictions or cutbacks being implemented or proposed in their states. So what Cindy is talking about in terms of the new direction for these waivers is something that's of great concern to us and to the state and local advocates with whom we partner. Next slide. So Cindy mentioned the Medicaid Act's flexibility, and I'm not going to talk a lot about that more, but I will just echo that already in the Medicaid program, states have flexibility, in some instances a great deal of flexibility when it comes to something like premiums and cost sharing. Congress has been explicit and comprehensive about the what states can do and also about the limits of what they can do. Sometimes there are things that aren't authorized by the Medicaid Act, and that's where waivers come in. They're called waivers because they're letting states ignore otherwise mandatory provisions. And of course, the experimental waiver provision is the one that we're focusing on here. Next slide. So the Social Security Act, Section 1115, I've also given the U.S. Code citation here, gives the Secretary authority to implement experimental pilot or demonstration projects that are likely to assist in promoting the objectives of the Medicaid Act. And when those things exist, the Secretary can waive compliance with one provision of the Medicaid Act. It is an important provision because it's the provision that lists things that the state plan need to or must or can include. And that waiver can happen for the extent and period needed to complete the experiment. So as Cindy said, this isn't intended to be a open-ended thing that the state's doing just to change their Medicaid program in some way forever. So next slide. The Section 1115 authority has been used over the years. I think you could tell from what Cindy was saying that the real difference here is that in the past, the authority has generally been used to expand the program, to get health services out to low-income people in need. What's different about this round is that it is highly tilted toward restricting coverage, cutting back coverage and eligibility. And the Kentucky Health Waiver really epitomizes that approach. Here is the timeline for that waiver. It's interesting because it really straddled the Obama and current administration. It was submitted back during the Obama administration on August 24th, 2016. There have been a couple of comment periods, as Cindy mentioned. There's a state comment requirement and a federal comment requirement. The last comments that were received at the federal level closed on August the 2nd, 2017. So at that point, no more comments came in. The comments were submitted talking about the waiver application that was pending under a regime and policy where work requirements clearly were not allowed. That had been the repeated position of the previous administration, and no other administration had ever approved a work requirement. On January 11th, earlier this month, the federal government, the Department of Health and Human Services, issued a Dear State Medicaid Director letter that, in its own words, established a new policy that encouraged states to impose mandatory work requirements and gave them guidelines for what they needed to do to successfully get permission to do that. The very next day, the Kentucky Health Waiver was approved. It contains mandatory work requirements, premiums for very low income people, cost sharing for non-emergency use of the emergency room, lockouts and termination for non-compliance with reporting requirements. There's, for example, a 10-day reporting requirement contained in the waiver where you need to report a change in income that will affect your eligibility within 10 days. I won't digress too much, but that's put in there as one of the features to make Medicaid more like commercial insurance, but I don't think any of us that have commercial insurance have a 10-day reporting requirement over the course of the coverage year. There's no retroactive coverage for the current program has a 3-month retroactive coverage provision. That's something that can be extremely important for hospitals, people who go in with acute conditions that can't apply for Medicaid for a period of time, and the requirement to provide coverage for non-emergency medical transportation was also waived. On January 24th, last Wednesday, a lawsuit was filed opposing this waiver. It's called Stewart versus Hargan. The plaintiffs are represented by our office, the National Health Law Program, Kentucky Equal Justice Center, the Southern Poverty Law Center, and then Jenner and Block is also counsel in the case. I'm going to go through a few of the features of the 1115 statute and its limitations, and use some of the situation from the Kentucky approval and the Kentucky lawsuit to illustrate what is happening here. Just to give you some very quick background on the Stewart case, there are 15 plaintiffs in this case. They live all over the state. They range in age from 20 to 62. They have different work. Their work varies. There's housekeepers, there's cleaners, there's homeschoolers, there's car repairmen, musician, a minister, a mortician, whose income depends on how many funerals he has over the course of a week or a month. There are people whose income varies, and some of them have no health conditions. They have been receiving Medicaid. Kentucky expanded Medicaid to the adult population through a state plan amendment, and these people walked through that door. Those without health problems have been getting annual physicals. Many of them do have health problems, however, high blood pressure, diabetes, other problems that wouldn't qualify them as disabled or frail, but those problems certainly get in the way of their ability to work or to hold a job. Some of them have mental health issues. They are all, to one extent or another, affected by and will be harmed by these various waivers that have been approved. The case has claims based on two particular laws. One is the Constitution. There is a claim that the Take Care Clause is violated by this approval. There's a timeline of activities by the administration and statements by the administration that evidence its intent to, using their words, explode the ACA, Affordable Care Act, of which the Medicaid expansion is a part. The very first day of this administration, an executive order was issued commanding federal agencies such as HHS to do what they could to dismantle the ACA. The letters and speeches that Cindy mentioned in her slide certainly are part of this effort to undo the Medicaid expansion, and these waivers fit right within this this concern that is evidenced by this claim. The other claim is based on the Administrative Procedure Act, and those of you who have worked with it know that there are two aspects of it. One aspect of the APA requires rules to be subjected to public notice and comment before they become final. And one claim in the complaint is that Dear State Medicaid Director letter, which announced new policy and sea change, a absolute sea change in policy. I'd say one of the most dramatic changes in federal policy that, I've seen since I began working in this area to impose this work requirement. The claim is that it should have gone through notice and comment before becoming effective. And then the other part of the APA is that when you make a decision, it needs to be a fair one. It needs to be based in the law. In other words, it needs to be consistent with the 1115 requirements for an experiment, for consistency with the objectives of the Medicaid Act, and for waiving only those provisions of the Medicaid Act that can be waived. And it can't be arbitrary and capricious. It needs to be based on the record that was in front of the Secretary, that is, those thousands of comments that were submitted to the Secretary during that comment period, albeit one where all 100% of commenters were commenting under a regime where work requirements were illegal until the day before the waiver was approved. Next slide. So just to quickly go through these requirements for 1115 waivers and some of the issues that are raised in this complaint, and I'm not really going to go beyond the complaint, which wouldn't be a surprise. And if you're interested in the complaint, it is posted on our website. I'm also happy to send you a copy of it. When Congress has talked about the experimental authority, it has said that the expectation is for that the Secretary will approve a project that has detailed research methodology and anticipates comprehensive evaluation. This project was approved with no operational protocol. The state will develop the operational protocol and is given permission to change the operational protocol without submitting it to the federal government. There are no metrics that are set forth in this. The state will develop some metrics at some point. Courts have also said that a simple benefit cut, which might save money, but has no research or experimental goal, would not satisfy this requirement. So if you look at something, for example, like termination of retroactive coverage in this context, that has no experiment attached to it. It's a benefit cut. It's cutting 3 months coverage from what was otherwise a part of this program. Next slide. The second part of the authority, or the second limitation on the Secretary's authority, is that the project promote the objectives of the Medicaid Act. Well, where do you look for that? That you look in the Act itself, and it's stated there at the very beginning of the Medicaid Act, and this is a quote from the Medicaid Act, a provision that's cited here, Section 1396-1, says that this Title 19 Medicaid is established for the purpose of enabling each state to furnish medical assistance on behalf of low-income families who don't have the resources to meet the cost of necessary medical care, and to furnish rehabilitation and other services to help the families attain or retain capability for independence or self-care. In other words, the purpose of Medicaid is to furnish medical assistance. As you all know, the Medicaid is just one part of the Social Security Act, which is our social safety net. And there are other parts of the Act that have other purposes. Go to the next slide, please. And just to use an example from another part of the Social Security Act, if you look at the purpose of temporary assistance to needy families, this is the statute that replaced aid to families with dependent children. So it's the welfare statute. The purpose of temporary assistance of needy families is, Congress has said, is to increase flexibility of states to do a number of things, one of them being to end the dependence of needy parents on government benefits by promoting job preparation, work, and marriage. So that's the purpose of TANF. The purpose of Medicaid is to furnish medical assistance. And of course, that's something that a court is going to have to decide, is whether medical assistance, requiring people to work, is an objective of the Medicaid Act, where the Medicaid Act's objective is to furnish medical assistance. Go to the next slide. Where those two things do exist, as I've said before, the Secretary can waive certain provisions of the Medicaid Act. This one provision, 1396A, is one part of the Medicaid Act. If you look at the law, there are 52 other provisions in there. A couple of examples of things that can't be waived because they are placed outside of 1396A are some cost-sharing limits, co-payments, for example. Co-payments for non-emergency use of the emergency room would have to be set forth consistent with this cost-sharing limit contained in the Medicaid Act. Premiums need to be established consistent with the provision cited here, 1396O-1. That provision prohibits premiums for individuals with incomes below 150% of the poverty level. These cost-sharing limits that Congress has placed in the statute are ones that are based on 35 years of consistent and redundant research. In fact, that's the most heavily studied aspect of the Medicaid program. And the study consistently concludes that for low-income people, co-payments cause them to avoid services, even needed services, and premiums erect a barrier to getting in the door in the first place. So that is a preview of the issues that we have set forth in the complaint. I guess a question someone might have would be, what is going to be the timing? The next step would be an answer or some sort of response from the federal government and the submission of an administrative record. And so that's what we are waiting for to happen within the next 45 to 60 days. And that's my my prepared remarks. And if anyone has questions, either of us are ready to go.
Great, thank you both so much. We did have one question, and it was Cindy about her perspective on how these new requirements will fall to frontline providers to implement and verify.
Cindy, hit your mute.
Thank you. Good question. States have been, and Kentucky included, have been looking to have their managed care plans implement some of these provisions, identifying individuals who may or may not be exempt, for example. So the one thing to note, and they're also bringing in, and Kentucky is bringing in its workforce agency and some of its other agencies to be able to provide some of the services. The waiver guidance actually, interestingly, says that no monies can be expended, no Medicaid dollars can be expended for the actual work support services provided. States can draw down administrative dollars. But I do think that providers will be, particularly managed care plans, will be looked to do some of the business of determining who's in and who's out, who's exempt, who's complied and who hasn't complied. And potentially that then moving down to some of the providers who are contracting with a managed care plan.
Another question was, is Kentucky enjoined from proceeding with the new approved waiver?
You're on mute.
Thank
Is
you, Cindy.
Kentucky,
Is it enjoined, I think was the question, for proceeding?
No, we are seeking an injunction in the case, but are not at that point. I will say that the rollout of this will begin this spring, but the actual implementation of it is in July.
and we invite other attendees, if you have any questions, to go to your drop-down box and write them into us. We unfortunately were unable to allow in over 100 of our attendees today, and so we will be providing the webinar and slides directly after this to everyone who has registered and for a link to share with them widely. We apologize sincerely for that.
Let me, while other people might be queuing up for a question or thinking about their question, let me just say a little bit more about the impact on providers. Obviously, there'll be an impact to the extent that there's disruptions in coverage, but it's also, providers will have to be constantly checking whether somebody that is even potentially in mid-treatment continues to be eligible and is at risk of then not getting paid if it turns out that the individual has been terminated for any of the reasons that have been authorized under the waiver. So there's potentially an administrative burden in terms of being charged with by the state implementing parts of the waiver, but also just day-to-day business of considering whether your patient yesterday can be your patient tomorrow, and what checks do you have to do to make sure that they're still covered and that you're authorized to provide treatment, at least with funding through the Medicaid program.
One of the things that we had seen in states that have expanded is that expansion in Medicaid coverage has been good for low-income people in terms of releasing them from the burden of medical debt. And in this situation that Cindy's just described, where people are going on and off of coverage, there's a great concern that the medical debt is going to begin a problem. And you can see that in like Indiana, which has a waiver right now, which it's testing, and we have our state partner there has a great experience with implementation of that waiver and can see individuals being charged and incurring medical debt where the processes aren't working as they should work. There isn't a timely decision on one thing or the other, and so the person gets charged, or the person goes without care because they don't have coverage, and you can't undo that lack of care. You can only go in at a more critical place where you either cost more to the Medicaid system or you have a higher out-of-pocket cost because you're not getting the coverage.
Can you discuss the potential impact of Governor Bevin's executive order?
Well, I would say to discuss that with Governor Bevin, but I think that we have some question. We're certainly looking into that. I guess our feeling would be that it's important not to shy away from enforcing laws that are meant to curb government authority, and particularly where here the use of that law is potentially affecting 95,000 people at least, and particularly where the result would be as a result of a court saying to the governor, you're acting illegally. The governor would then turn around and end coverage for everyone, he says, who's covered by this program. Hundreds of thousands of people who are covered by this program, which is very popular in Kentucky.
We're getting a number of questions now. One of them is, do you think that the work requirements will have implications for the Americans with Disabilities Act? For instance, might work requirements have a disparate impact on people with disabilities who fall under the ADA definition of disability, but are not excluded from the work requirements?
Certainly, there are implications for application of the work requirement. Also, as another example, the drug screening and testing proposal out of Wisconsin certainly has implications for the Americans with Disabilities Act. Some of the broad waivers that states are requesting to waive the way that coverage of institutions for mental diseases is set up, that could implicate the Americans with Disabilities Act. The Secretary certainly cannot waive the ADA, can't waive the Constitution, can't waive the Fair Labor Standards Act, which says that people get paid a minimum wage when they're working, and when you're being forced to work or forced to volunteer, which isn't volunteering anymore, those laws are implicated as well.
And I will say in the guidance that the administration issued earlier this month on work requirements, they flagged in a number of different parts of the guidance the ADA itself and the implications of the ADA to a state's administering a work requirement. It did not spell out what exactly what a state needs to do to be on safe ground with the ADA. It's obviously not for the CMS to either waive or opine on what meets the ADA requirements, but so it pretty much puts it in the hands of states to look carefully at those provisions of the ADA and to think about really with every step who's exempt, who's not exempt, what are the methods by which a state asks somebody to show their exempt status, all different aspects of implementing this kind of program. CMS itself flagged has potential ADA implications.
And following up, one of our viewers said that as far as they know, no state has actually tried to track functional impairment status within those who joined under the ACA Medicaid expansion. Has Kentucky publicly given any indication of just exactly how it will distinguish those who are exempt because of disability from the work requirements of all of those who enrolled in the expansion population?
I'm not sure I heard is the question whether we know how Kentucky is going to implement this to avoid an ADA violation? If that's the question.
It's hard to hear the very beginning of the question.
As far as this viewer knows, no state has actually tried to track the functional impairment status within those who joined under the ACA Medicaid expansion. And so whether or not they've given any indication of just how they're going to distinguish those who are exempt. No.
No, I mean, that's one of the things that is of concern, which is that there's a lot of permission granted here using an experimental authority where you would expect there to be a more demanding foundation or template out of the box, so that you would know who is being experimented upon and who isn't, with a little bit more, with some more clarity than we have here.
Another question is,
You accept this as an experiment.
your previous statement was that Medicaid funds are not to be expended on administrative expenses. How does that apply to managed care companies who are receiving Medicaid funds to administer the plan? Administrative costs to the plan may be significant.
So first let me clarify the statement. So states can spend administrative funds, Medicaid administrative funds, state and federal funds, on changing their IT systems, changing their eligibility application, coming up with a screening mechanism, and issuing notices of termination, the functions that are in the four corners of the Medicaid program, even if they are having to do with the implementation of the waiver authority. What the guidance said is that states cannot use federal dollars, cannot use Medicaid dollars for, is to provide the work training, provide the child care, provide the transportation, provide, job search assistance for people. So, so they're not providing any additional resources to supplement what may be available from other federal programs or state sources to actually provide concrete support for people who are subject to the work requirements and need those kinds of assistance. In terms of the managed care question, it's an interesting question. There are often Medicaid administrative requirements that sometimes a state will delegate and contract with their managed care plan to do. And when they do that, they are required to come up with a actuarially sound rate for the managed care plan and to pay the managed care plan appropriately. There's a lot of discretion in terms of how that gets established and whether or not plans will receive additional dollars for these if they're given new responsibilities under the waivers is really a matter of contract and pricing between a state and in its managed care plan. There are some general rules on actuary soundness under the federal law, but this is one of the areas where states are given quite a bit of flexibility. That being the case, we may see plans raising their hands and saying there's a problem in terms of the responsibility being shifted onto them if they don't feel like they're receiving adequate administrative support for it.
When Kentucky says that 100,000 people will lose coverage, have they provided a distribution of health profiles of these individuals, such as the percent that have a chronic illness but don't meet the definition of medically frail, or those with borderline intellectual functioning, i.e. IQ of 85?
I don't believe so. I think that number is derived from the way that they calculated their neutrality, and it's. Did you see anything like that, Cindy? I don't think so.
No, and you're exactly right. Then they didn't particularly say 95,000 people would be lost. They were projecting what the enrollment would be with the waiver, and the enrollment, those numbers show a drop-off of 95,000 people, but there's no further delineation of which parts of the waiver may be attributable to coverage losses or the particular characteristics of the individuals who might lose coverage.
And our final question was, when will Jane know whether an injunction will be issued?
When someone asks for an injunction and it is ruled on. I don't mean to be flippant. I just, there's just a lot of questions about when to seek an injunction. And of course, proving the need for the court to issue it. It's not something that's going to or can, litigation time is sort of like hospital time. It moves slowly oftentimes, but there is a date here that's going to have to be dealt with, and that's the July implementation date.
Great. Well, on behalf of the section of Civil Rights and Social Justice, we thank you so very much for giving us your time today and talking to us about this issue and shedding some more light on these issues. We will be making this PowerPoint and the recording available on our website and sending it to all of the registrants and attendees. So again, thank you so very much, and we thank you for your time.
Thank you.
Thank you.